Welcome to The Explainer. All right, if you're a medical trainee, you know the heart's electrical system can be, well, pretty complex. So today, we're going to break down one of the most important interventions we have, permanent cardiac pacing. We're going to give you the essential, need-to-know framework for this amazing, life-saving technology.
We've laid this out in 5 key parts. We'll start with the real basics of why we even need pacemakers, then get into who gets them, the tech involved, how we choose the right one for the right patient, and finally, what you need to look out for after it's implanted.
Okay, so to really get a handle on this, we've got to start with the fundamental problem. And your heart is this incredible electrical pump, just perfectly timed. But what happens when that super intricate wiring starts to short circuit?
At its absolute core, the problem is a failing conduction system. And this can lead to what we call bradyarrhythmias, those abnormally slow and sometimes dangerous heart rhythms. A pacemaker doesn't actually fix the bad wiring. Instead, think of it like a backup generator. It just sits there quietly in the background, but the very second the power goes out, it kicks in and makes sure the heart keeps beating at a safe, steady rate.
So we have this incredible little backup generator. The next obvious question is, who actually needs one? And while there are a ton of specific guidelines, the big picture is actually pretty simple. The decision to implant almost always comes down to one thing. A patient has an irreversibly slow heart rhythm, and it's causing them real-world symptoms. Now here's a tip that's going to simplify all of this for you. Even though the official list of indications is long, just 2 conditions account for the vast majority of all pacemaker implants. If you can really master these 2, you've basically got the core of clinical pacing down.
First up, we've got sinus node dysfunction, or SND. It's the single most common reason we put in a pacemaker. And all it means is that the heart's own natural pacemaker, the SA node, is failing. It's either too slow when you're resting, or it doesn't speed up like it should when you're active, and that leads to symptoms like fatigue and dizziness.
The second huge reason is acquired AV block. So in this case, the signal starts out just fine in the atria, the top chambers, but it gets stuck somewhere on its way down to the ventricles. This completely breaks that critical synchrony between the top and bottom of the heart, causing a really dangerously slow ventricular rate.
Okay, so we know why a patient might need a pacemaker, but what is this technology we're actually using to solve these electrical problems? Let's geek out a little bit on the hardware.
When it comes to the actual hardware, you're going to see 2 main types out there. For decades, the standard was the transvenous system. That's got 2 parts: the generator, a little box that goes under the skin in the chest, and these wires, or leads, that we thread through the veins right into the heart. But now we have this incredible alternative, the leadless pacemaker. It's an all-in-one capsule about the size of a big vitamin that we put directly inside the heart. No wires, no chest incision. It's pretty amazing.
And the benefit of this new tech isn't just theoretical. The data is just stunning. A huge registry showed that these little leadless pacemakers had a 63% lower risk of major complications. And why is that? Well, it's because you get rid of the 2 biggest sources of problems: the leads themselves, which can break over time, and that surgical pocket in the chest, which can get infected.
So this brings us right to the core clinical question you're going to face. With all these different options, how in the world do you choose the right device for your specific patient?
Yeah, this is definitely not a one-size-fits-all situation. It's got to be highly personalized. We have to ask a few key questions. First, which chambers actually need our support? Is it just the bottom chamber, the ventricle, or is it both the top and the bottom? We also have to look at the patient's anatomy, their risk for infection, and a really important one: how often do we actually think this pacemaker is going to need to fire?
Now listen, this is one of the most important changes in modern pacing. It's not just about if you pace, it's about where you pace. For decades, the standard was to stick the lead at the very tip, or the apex, of the right ventricle. The problem is, this creates a really unnatural contraction. It makes the walls of the ventricle beat out of sync, which is a condition we call dyssynchrony. So we've moved to much smarter locations, first to the septum, and now to what we call conduction system pacing, where we actually try to tap right into the heart's natural wiring to get a much more synchronized, efficient heartbeat.
And this isn't just a cool theory. Large studies have shown that placing the lead to pace the left bundle branch area to mimic the heart's natural sequence is tied to a lower risk of heart failure hospitalization and even death compared to that old-school RV pacing. I mean, it's a total game changer.
All right, let's fast forward. The procedure is done, the device is in, patient's feeling way better. But our job is not over. What are the key things you absolutely have to watch out for in the long run?
While these devices are incredibly safe, you've always got to be on the lookout for potential problems down the road. Device infection is the really big one. It's super serious, and often means the whole system has to come out. Over many years, the leads can wear out and break, and sometimes, kind of ironically, the pacemaker itself can actually trigger other abnormal heart rhythms. So, when you're looking at an ECG, you can spot these malfunctions if you know what to look for. The first is failure to capture. You'll see the pacemaker spike, that sharp little vertical line, but then nothing. No QRS complex follows it. It's exactly like flipping a light switch, but the bulb doesn't turn on. The signal was sent, but the heart didn't respond.
Then there's failure to sense. This is when the pacemaker fires when it absolutely shouldn't, usually right after the heart has already produced its own beat. This is a listening problem. The device isn't seeing or sensing the heart's own activity, so it chimes in at the wrong time. It's like someone interrupting a conversation because they weren't paying attention. The timing's all wrong. And finally, if you see a long, scary pause on the ECG where the pacemaker absolutely should have kicked in to prevent a slow heart rate, but it didn't, that's a failure to pace. This can happen for a bunch of reasons, like if the device oversenses some electrical noise and thinks the heart is beating when it really isn't.
So all of this leads us to a final, really exciting question. We've gone from just keeping the heart from beating too slow to trying to pace it in the most natural, physiological way possible. As this technology just keeps getting better and better, could we one day completely eliminate pacing-induced heart failure altogether? It's a really exciting thought for the future of cardiology.